Okay, done with the cortex hyperfunction. Let's move to the medulla. Most commonly, these are neoplasms, but really they're uncommon overall. In adults, the most common cause is pheochromocytoma. In children, it's neuroblastoma. The difference there, in neuroblastoma, you don't necessarily have hypertension like you're going to find in pheochromocytoma. And also, you're going to find the NMYC gene or whatever. I don't know if she's talked about that, but I thought I'd throw it in there. So pheochromocytoma, this is the most common in adults for the hyperfunction disorder of the medulla. So normally, the medulla secretes epinephrine, norepinephrine, and dopamine. And in this case, most of these pheochromocytomas do mimic the normal medulla and secrete those. So your findings are going to be high blood pressure, headaches, sweating, tachycardia, pallor, or the 5 Ps, which was the first aid thing, pressure, pain, perspiration, palpitations, and pallor. And these are due to sporadic release of massive amounts of these catecholamines. So you're going to have someone come in with spells of headaches, high blood pressure, profuse sweating, whatever, that kind of thing. But it's going to be in spells as opposed to hyperaldosteronism, which will be consistent. So clinical write-up. We're going to check the urine epinephrine, norepinephrine, and also, excuse me, we can do a 24-hour urine VMA and metanephrines, which those are just degradation products of epinephrine and norepinephrine. So that's epi, NE, or VMA, and metanephrines. And then we can do a CT or an MRI. Okay, so another thing to differentiate this from hyperaldosteronism is you're thinking in hyperaldosteronism. This mimics that. You're gonna have low K, but here you're gonna have normal K. You're gonna have normal potassium because it's not messing with that cascade. So the other features of this, it's called the 10% tumor because 10%, there's a 10% risk of malignancy, 10% are bilateral, 10% are hormonally active, and 10% are extra adrenal. And I took that as being outside of the medulla in neural crest origin, so in the sympathetic chain, one of those ganglia also having something similar to this. And also that they are highly vascular and prone to hemorrhage and necrosis. Nasty. Okay, so treatment, alpha antagonist, phenoxybenzamine and phentolamine, and then surgical removal. So the prognosis, 5-year survival post-op is good. It's 95% if it's benign. Malignant is less good, less than 50% survival. Okay, done with hyperfunction disorders. We're going to talk about the hypofunction disorders. So first we're going to talk about adrenal insufficiency, and I believe this is the only, so we're going to talk about adrenal insufficiency. So findings, so you're going to have low aldosterone, you're going to have low cortisol, you're going to have low sex hormones, you're going to have low androgens, you're going to have insufficiency. So your findings are going to be hypotension, you're going to have fatigue, weakness, weight loss, lightheadedness from the orthostatic hypotension, hyperkalemia as opposed to hypo because aldosterone is not there, so you're having a buildup of potassium, and then hypoglycemia because you're having insulin unopposed, so you're constantly storing glucose as glycogen. Cortisol isn't coming in and saying, hey, we need more glucose in the blood, get it out there, okay? And also you're going to have skin pigmentation. We'll get back to skin pigmentation because that's a differentiator. So let's talk about etiologies. We have primary, which is Addison's disease, and secondary. So primary Addison's disease can be due to any sort of destruction of the adrenal gland. So it can be due to autoimmune, which is the most common in the US. It can be due to infection. It can be due to cancer. So what you're going to find in primary, so you're having destruction of the adrenal, is you're going to have ACTH high because that axis is working. That pituitary hypothalamus axis is working. It's sensing low cortisol and sending more ACTH. Cortisol is going to be low. We talked about that. So is aldosterone and androgens. Secondary insufficiency is due to a hypothalamic or pituitary disease. So we're just upstream now. We're just flipping it. So this is not going to be associated with high ACTH. You're going to have low ACTH, and cortisol is going to be low because that's the whole point here. But the low ACTH is due to the fact that your problem is up at that part of the axis. And the big difference between these two is the skin pigmentation, what I was talking about before. In primary, you're having excess ACTH that's not necessarily being utilized, and it's being produced in high amounts. And a precursor for melanin stimulating hormone, I think that's what is melanin stimulating hormone, is a byproduct of that or whatever. So that is going to lead to hyperpigmentation in the type of adrenal insufficiency. Addison's primary, where you have high ACTH, you're going to have that hyperpigmentation. Whereas in secondary, hypothalamic, you're going to have low ACTH, no hyperpigmentation. So that's a differentiator there. So clinical write-up, you're going to check the plasma ACTH. You're going to check cortisol. You're going to see if you can stimulate ACTH production. You're going to do co-syntropin. If you can stimulate the pituitary to release ACTH, then you know that part of the axis is okay, so you're going to be worried about the adrenal. If that doesn't work, then you're going to be thinking at that point of the cascade. Okay, so I think we're done with that. Next, the last, I think, hypofunction disorder we're going to talk about is hypoaldosteronism. So this is going to be the opposite of hyper. You're going to have low BP, low sodium, and high potassium. Okay, just the opposite. And you're also going to have normal cortisol to ACTH stimulation. So the problem isn't necessarily with the whole adrenal gland. You're talking just the glomerulosa, just aldosterone. There's two etiologies that were talked about. The most common one is hyporeninemic. So you're having low renin from the kidney. So you're having mild renal failure, common seen in diabetics. There can also be a defect in aldosterone synthesis from the one enzyme deficiency we talked about, 21 hydroxylase, right? That was the one where you had no cortisol or aldosterone, everything was going to androgens, you're going to have hypotension. That one, as well as angiotensinogen unresponsiveness, which is a precursor to angiotensin and then to aldosterone. So treatment, replace the aldosterone with fludrocortisone, fludrocortisone, tough one, and then replace your sodium, reduce your sodium intake and give furosemide. A little confused about that. But yeah, so fludrocortisone and then reduce sodium and give furosemide. So we're done with all the disorders. We're going to go on to the OMM correlates. This should be quick. So we're talking viscerosomatic reflexes here. We're talking in the T8 to T10 region. That's going to be our area of focus. And then Chapman's points. We have anterior and posterior. Anterior are the ones on the belly button. We learned about these. You have 5 to 7 centimeters superior to the umbilicus, and then 2 to 3 centimeters lateral to the umbilicus. On the posterior side, we're talking midway between the spinous process and transverse processes of T11 and T12. So viscerosomatic, T8 to T10, okay? And then we're having posterior findings on T11 and T12, which is kind of effed up, but whatever. Okay, so then lastly, the glucocorticoid therapy guidelines. These are kind of obvious, so I'll just run through them. So using them only if there's published evidence of an objective benefit, and only after other treatments have failed. And then after initiated, we need to set an objective criteria for response. So then when using them, we need to administer a sufficient amount of the steroids for a sufficient time. We need to administer a sufficient amount of glucocorticoid for a sufficient amount of time to achieve that desired objective response, and then use them no longer than necessary because of the nasty side effects, Cushing syndrome that we've been talking about, and then to terminate them if the benefit is not observed, if complications arise, or if the max benefit is achieved that we said originally. And then to evaluate, we need to talk about some contraindications. Absolute, any active infection, especially TB, glucose intolerance, diabetes, pre-existing osteoporosis, pre-existing peptic ulcers, hypertension, cardiac disease, or psychiatric disorders. And these are just come from Cushing syndrome symptoms, right? If any of those are there, don't give it. And then our goal is to use the smallest possible dose relative to the patient's weight. If the patient does not tolerate, okay, so these are just two little, I guess, things I put in here at the end. So if we need to use the smallest possible dose, okay, duh. And if the patient does not tolerate the alternating day treatment, consider adrenal insufficiency. So, I don't know. I'm done. I've taken way too much of your time. 30 minutes and 35 seconds. Peace. Love you guys. Enjoy.